شكرا. طبعا الديبيت كان ممتع، ولكن لو احنا عملنا فيكسيشن لبيشنت بروفايل، حكينا على عيان معين سنه كام ونوعه ايه وبياكل ايه وبيشرب ايه وبيشتغل ايه ووزنه كام وحاله الهارت والكدني ايه، كنا هنتفق على العلاج. لكن على المطلق دكتور مصباح صح والدكتور فريد دكتور ياسر صح، ولا هيبتدي بجي ال بي 1 صح، ولا هيبتدي بدي 4 صح، فكله مظبوط، فمفيش عندنا حاجه غلط. لازم نفيكس بيشنت بروفايل عشان نتكلم، لكن كلهم نقدر نبتدي بيهم. المهم كل سنه وحضراتكم طيبين، والنهارده يعني اخر يوم في المؤتمر، سعدنا بوجود حضراتكم. انا هتكلم عن، طبعا بشكر استرازينيكا على دعوتي ان انا اكون سبيكر بالنسبه لهم النهارده. المكان ده فين؟ اول سؤال بقى نعمل ديبيت جديد. طيب المكان ده فين؟ Where is those photos from? From Fayoum. Yes, this is Fayoum. Inshallah, we are arranging a meeting there in Fayoum. You know that diabetes is spreading, diabetes is increasing, and diabetes atlas is changing every 2 years. In Egypt, you have more than 11 million people with type 2 diabetes, and in practice, most of those patients are uncontrolled all over the world and in our region. This study, the Discover study, which explores how many years were spent before changing the baseline therapy for type 2 diabetics. It was done in so many countries, including Egypt. It includes about 16,000 patients, 583 patients from Egypt. I have 13 patients of those patients. I participated in this study, and it concludes that most of the patients all over the world are not controlled, and the mean A1C in the world was 8.3, and the mean in the region was 8.7. So it is the highest among those in the map. What the problem? The problem that we know that diabetes, especially uncontrolled diabetes, increases the risk for microvascular diseases by more than 50% in 10 years, heart failure for more than 33% 4 years, stroke 72% after 5 years, and acute MI more than 50% after 5 years. And we also know that the diabetes affect the vascular system. So the heart and the kidney, through its vasculature, are connected. And any affected organ of them or system of them can affect the other. And it is better to understand or to revise that heart failure comes the second most frequent events. Patient with heart failure comes second of the cardiovascular events after peripheral arterial disease. In this study that includes so many patients, about 2 million patients. And heart failure, the presence of heart failure and hospitalization of heart failure increases the likelihood of cardiovascular mortality. So heart failure is a very important item in the cardiovascular affection in diabetic patients. Also, kidney affection throughout all the stages. In this study done from 2007 till 2002 and 12, all stages of kidney affection, chronic kidney disease, are more in diabetics than in non-diabetics. And the presence of kidney affection, whether albuminuria or decrease in the estimated GFR, will increase the mortality of those patients. So the presence of heart failure will increase the mortality, and the presence of renal affection, CKD, will increase the mortality of diabetic patients. So what we can do for those patients. We can do regimens of medication that control the blood glucose with extra glycemic effect that should be safe. Together, we can improve the outcome of those patients. All we know that the ominous octate, that diabetes comes from so defect in the pathophysiological system, so many organs. So if we choose a drug combination, we can affect or decrease or improve or correct the defect that may be present. So dapagliflozin with metformin can improve more than one pathophysiologic defect. In this study, compared to DDP4 inhibitors, dapagliflozin provides better A1C reduction with better weight loss and better even blood pressure reduction. And all are important to avoid the vascular complications of diabetes. Also, compared to the DDP4 inhibitors, dapagliflozin provides double reduction in the fasting blood glucose and also in the 2 hours postprandial in this study. So, as effective, it is effective. Patients on DDP4 inhibitors who are not controlled, whether in metformin or not, we can add dapagliflozin to them. In this study, dapagliflozin versus placebo as monotherapy decreased the blood A1C, the hemoglobin A1C, by about 2.6%. And for those patients who are not controlled on sitagliptin, whether with metformin or alone, after adding dapagliflozin, the A1C significantly drops. Even patients on insulin, basal insulin, whether with other oral anti-diabetic medication, metformin or others, after adding dapagliflozin, we got more reduction of the A1C with more significant reduction of the weight, and also the insulin dose was decreased by about 20 units a day. This is important also. And the conclusion of this study that dapagliflozin can be given to patients on insulin if they are not controlled for better control with no hypoglycemia, with less weight gain or even some weight loss, and with decrease of the insulin dose. The second part is to delay the complication or to prevent the complication. We know that complications of diabetes come from that the patient has multiple risk factors, and those risk factors are increasing. So the patient may have heart failure or CKD. This will be interpreted to a form of cardiovascular events. And if the events are repeated, that will lead to death at the end of the day. And we can prevent this if we decrease the risk factors or decrease the number of the attacks. And from that meta-analysis of the SGLT2 inhibitors, we know that they decrease the cardiovascular events, they improve the cardiovascular outcome in patients with type 2 diabetes in various studies. One of these studies, the DECLARE study, which was done on 17,000 patients, some using DABA, others using placebo. Some of the patients, the patients are type 2 diabetics, aged more than 40 years. 40% of them have established cardiovascular disease, and 60% of them have no cardiovascular disease, but have multiple risk factors. The estimated GFR are chosen to be above 60, and this is the status of the albumin-creatinine ratio at the end of the slide. And the results we got from the DECLARE study that there is relative risk reduction for cardiovascular death or heart failure by 17%, and for renal composite endpoint by 47%, for deterioration of the estimated GFR by 64%, and for new renal abnormalities, new onset albuminuria by 21%. Here, dapagliflozin slowed the renal progression, and even it improved the albuminuria in some patients. It improved the grade of albuminuria. So it can maintain or even improve the renal outcome. The third part is the safety. And when it comes to safety, this is a study comparing the safety from more than 200 randomized controlled trials. It indicates that SGLT2 inhibitors, including dapagliflozin, as regard all adverse events, they are the same compared to the DD4 inhibitors. Serious events towards in favor of SG, hypoglycemia, and major hypoglycemic events also are in favor of using SGLT2 inhibitors. What do the guidelines say? The guidelines are focusing on patient-centered care. We are treating diabetes not to improve the blood glucose only, but also to prevent the complications and to optimize the quality of life of our patients. In order to do that, we should do weight management and lifestyle modifications, including weight management program, cardiovascular risk factor management, smoking, lipidemia, obesity, glycemic management, sure, and we should choose drugs that control diabetes and have additional benefits like cardiovascular and renal protection. All of us know the importance of glycemic control. The glycemic control will delay or postpone or prevent diabetic complication, whether the microvascular or the macrovascular, known from all the mega studies done before. And the combination therapy, when we look for efficacy, we should start with combination therapy from the start to have better results, more effective drug with less side effects from the start to overcome the initial delay of treatment. And all of you know this complicated, complex slide that talks about everything. We should sit with the patient, talk with the patient, know the risk stratification of the patient, his lifestyle, his profile, and discuss with him the treatment option available and side effects of each one, the cost of each one, and what to do if any complication happen, and we can rechange and reevaluate our program or our approach every visit. So all of you know that this patient-centered approach. And also, all of you know this last guideline that says that SGLT2 inhibitors are mandatory for patients with established atherosclerotic cardiovascular disease, whether MI, stroke, heart failure, CKD, and also it is indicated for primary prevention, as the declared say, that it is beneficial even for patients without established cardiovascular disease, but with some risk factors, and even if you look for efficacy, because SGLT2 inhibitors and metformin are now classified as an effective medication for type 2 treatment. So, to conclude, the benefits from dapagliflozin, Zegado or Forxiga, A1C reduction to target, primary and secondary prevention from heart failure, progressive kidney disease, and MI, significant weight reduction, insulin dose decreased or decreased the insulin dose, used by the patient if combined with insulin. This is the enclosed leaflet of the drug. And those are some photos from Fayoum. I hope we can arrange a meeting, a WIDA meeting there in Fayoum in the next few months. And all of you are invited to visit this new city. This is one of the old pyramids at the ancient era. This is one of the oldest things, the UN Wadi al-Hitan. This is 40 million years. These are the desert of Fayoum, waterfalls, obelisk, museums, and thank you very much.